All right, everybody, here we go. We're going to start on our documentation review. First thing I want to start off with, guys, is just make sure you're reading over your key terms. You're going to see a lot of them come across on your test, so be familiar with them and what they are, and the definitions and how you can apply those while taking your test. Um, Remember the five purposes of the patient record. Make sure you're familiar with that. Remember, one is documented communication. Two, permanent record for accountability. Three is the legal record of care. Four is for teaching. And five, research and data. Make sure that you're familiar with that. Make sure you know all five. Also, remember what auditors are. Auditors are those people in the healthcare field, such as a QA nurse, a QA LVN, quality assurance. They're the ones who are going to come back and review your chart. They're going to review your documentation. They're going to make sure that everything is up to par in regards to the way it's documented, the way it's lined out, the care that was given. They also do the coding for billing purposes as well. So they're going to make sure that everything's exactly the way it's supposed to be. And if there's anything that needs to be changed or something, they might come back to you in regards to that. Also, your peer review. Remember your peer review. Those are a group of people that sit at the hospital. It's a group of your peers, other nurses, people from other clinical areas such as laboratory services, radiology. They sit on a group or a panel that also review documentation and charting. They also review any situations in regards to patient care. If there was a complaint about something, that might need to go in front of the peer review group. That's who that would be presented towards. And you might even have to go explain your case and the reasons for your documentation or the reasons for your actions of what you did or did not do in regards to patient care. And that would be in front of your peer review at the institution that you're working at. Remember your DRGs. DRGs, your diagnosis related groups. Your DRGs are those hundreds of groups of diagnoses that are out there that are what your insurances, Medicaid, Medicare, private insurances are going to pay out on. You know, for example, you have a female who's had hip replacement, and based on that diagnosis related group of total hip replacement surgery, the insurance companies are going to pay out X amount of dollars based on that diagnosis related group. So what we need to do at the hospital, your case managers, your nurses, they're going to follow what is called a clinical pathway, which is a pathway in regards to the care plan that you're going to follow to maximize your payout that you're receiving for this diagnosis related group from the insurance companies. So you're going to make sure that the patient's up and walking in a certain amount of time, that they're able to tolerate pain within a certain amount of time. They are ambulating so many feet, and you want to do that within a allotted amount of time in regards to maximizing your payout back from the insurance companies. And everything gets documented in your nurse's notes. Remember, everything is going to go inside your nurse's notes, guys. You know your electronic health records, your EMRs, your MAR, your MAMAR, your medical administration records, medication administration records. Make sure you're familiar with all of that. I also want to talk about the SBAR. The SBAR is your form of communication with the doctors, or even when you're getting a report from another person. Your SBARR, if you're talking to a doctor, it's your situation. You're explaining what's going on in regards to the patient, to the physician, or to another nurse. You're giving a little bit of background, whether it's a little history on the patient, could be laboratory services, diagnostic studies that were done, and you're giving a little bit of background, what's going on. Give your assessment. Talk about, what the medications were that the patient has, what's going on, and what you feel is happening with the patient. And then your recommendation as well. Give your recommendation to the physician or another nurse in regards to what the care should be and what needs to follow. For the doctor, you say, could we give them a prescription for morphine for the pain? And then if the doctor does give you orders, make sure you read it back. Make sure you read it back, clarify your orders with the physician. Also, be familiar with your basic guidelines for documentation, guys. Look at page 42 of your chapter, that box 3.2, make sure you're familiar with all the basic rules of documentation. Read over it and study it. Make sure you're very familiar with that. We'll go over just a couple real quick. Document should have the correct patient's name, date of birth, date and time if appropriate. Try not to use abbreviations if all possible. I know we talked about the abbreviations. There are some that are approved and that are not approved to use in the facility. Just clear yourself of that liability by putting something you're not supposed to, by just writing out the complete word. Try not to use abbreviations. Be timely, specific, accurate, complete in what it is you're writing. Write legibly. Make sure you're using proper grammar, punctuation. It's very important. Also fill in all the spaces. We talked about when you're writing your notes, you get halfway through the line and you're done with your notes. Draw a line through the rest of that blank space and then write your name or initials at the end. Do not leave any blank spaces over there. That might leave you open for liability. If somebody else came along and started to document on something and your signature's at the end, it's going to look like you were the one that was doing the care for whatever it was that other person wrote. So protect yourselves, fill in all the blanks, don't leave anything open, and sign it at the end. Don't chart for anybody else. If somebody's helping you, don't give them your password. Don't allow them into your computer. If it's your charge nurse that's helping you, she can log in under her own number and name and document whatever it is she needs to do for the patients. Don't allow them to log it underneath your number. Also, write only your observations and care that was given. Don't speculate. Don't give your opinion. Put just what you saw and what was done and any statements that might be important in regards to what the patient might have said. And that's it. Don't speculate. Don't elaborate. And try not to be vague in your notes either. Don't just say patient status unchanged. Give a description. What is the patient doing? How are they feeling? Any descriptors. Paint a nice picture for the doctors or the other nurses that are coming in after you in regards to the status of the patient. Chart any orders that were given to you by the doctor. Make sure that those are documented and clarify the orders as well, and document that you clarified the orders. Whenever you're making an error, make sure that you're drawing a line through whatever the error is, initial it, and then continue on with your notes. If you have a late entry, just make sure you document that you have that late entry. Document the date and the time that you're actually making the entry, and then note that it's a late entry and document whatever care it was that you did that it was supposed to be done at that appropriate time. And then continue on with any other notes that you have after that. Okay. Also, on page 43 of your textbook, the legal guidelines for documentation. Make sure you're familiar with that. Where it talks about do not erase or use correction fluid. It looks like that you're trying to omit something and hide something from the record. So, draw that single line through it, initial the error, and then continue on with your notes. Don't document any retaliatory or critical comments that, about a patient or that maybe another healthcare professional might have said. One, it can be used for evidence, and it looks unprofessional, and it could give indications to poor quality of care. You enter only objective and descriptions of patient's behavior, and that's it. Don't use quotation marks when documenting in regards to things that the patient said, but be objective in your notes. Okay. Document as you go. Don't save it all for the end. You're going to find that you're going to omit things that might have been needed to be documented that were not. As you're seeing your patients, you have your workstations, you have your POCs, your point of care stations, your WOWs or your COWs, computer on wheels. Take them with you as you're doing your assessments, asking questions, interviewing the patient. You can also be documenting on your notes at that time. And it'll help avoid you from omitting any information that might be needed to be documented. Okay. Remember your traditional chart. Your traditional chart would be, a chart that's got all these little tabs in it. Okay, be familiar with that. Know the different tabs. And not every facility is going to have them in the same order. They're going to be in different orders, but you're going to have your basics. You're going to have your patient's demographics. It's going to have information about where the patient lives, their insurance, their religion preference, the doctor's name, any next of kin information. It's going to have all of that in your demographics. Also, that sheet that's in the very front that gives you all that information is called a face sheet. Make sure you know that as well. You might see that on the test. Make sure you know. Face sheet is the sheet that's generally in the front of the binder. That's going to have patient's demographic information, insurance information, religious information, doctor's information, next of kin, all of that good stuff. Okay. Also, the other different tabs you're going to see progress notes, history and physical, doctor's notes, doctor's orders, nurse's notes. You might even see rehab notes, radiology, laboratory services. All of these are different tabs that you'll find in a traditional block chart. Okay, make sure you're familiar with that. Okay, also be familiar with your different kinds of charting. Okay, we'll go over some of them right now. We'll discuss some, like your narrative charting. You know, your narrative charting is it flows. Like if you're starting from your head to toe assessment, you know, make sure you're starting with the patient. You know, walked into patient's room, noted patient sitting up in bed watching TV. Patient is alert and oriented ×3. Upon assessment, patient's eyes are perla, which means pupils are equal, reactive, and light accommodating. You could say oral mucosa is pink and moist. And then work your way down. Go to the chest. Chest is symmetric. Lung sounds are clear to all lobes upon auscultation. You know, abdomen is soft, non-tender, flat. Maybe it's distended. Make sure you're documenting whatever it is. Bowel sounds present to all 4 quadrants. That's your narrative. You're making it flow. You're working from a head to toe manner, and you're making it flow as you're doing your assessment. Okay, that's your narrative charting. You're going to use data that's subjective, objective, and make sure you're doing it in that narrative form. Okay. Also, you have your problem-oriented medical record, your POMR. Okay. It's remember, it's organized according to scientific problem-solving systems or methods. Okay. Information is accumulated in a data or database from the history and physical examination and diagnostic tests. It's used to identify and prioritize health problems on a master medical or other problem list. Okay? Remember, your problem list contain active, inactive, potential, and resolved problems that can be all documented within your problem list. Remember forms of documentation that you would use with the problem-oriented medical record. Remember the SOAP and SOAPier. Do y'all remember what that means? Okay, SOAP, SOAPE. Remember, it's on page 44 in box 3.3. It means subjective. What is subjective data? Do y'all remember subjective? Subjective is anything that the patient states in regards to how they feel. That is subjective. Objective data, which is the O of SOAP, is what you see, what you observe. That's objective. Okay? And then, of course, your assessment data, the plan, what it is you're going to do, and then your evaluation. Okay? And then you even have the modified version, which is SOAPier. Remember, subjective, objective, assessment, plan, intervention, evaluation, and revision. Pretty self-explanatory, guys. You know, your intervention, you're going to do your plan. What is the intervention to the plan? What is it that you saw? What is it that you're going to do? You're going to give medication for the patient's pain. That's your intervention. Your evaluation is your follow-up to whatever the intervention was. You're going to go back and follow up to see how the patient's doing with that intervention. Okay? And then your revision would be anything that you might need to change. Maybe the pain medication wasn't working. You need to get new orders from a doctor. That's a revision. Okay? Continue on. Your focus charting format, which was developed by nurses. It's a modified list of nursing diagnoses and is used as an index for nursing documentation instead of problem lists. Remember, your problem list is going to be things that are there in regards to your medical diagnoses, things that the doctors have put forth. You know, patient's got high blood pressure, elevated cholesterol, they're on medications, and you're going to document on those medications in regards to how the patient's reacting and how effective they are. That would be your, you know, problem oriented in regards to documenting on those. Your focus charting is in regards to nursing diagnosis.